With more screen usage and indoor time, myopia, also known as nearsightedness, is increasing and getting worse in children. Now, certified eye doctors can prescribe MiSight One Day, the first and only FDA-approved soft contact lens to slow myopia progression in age-appropriate children. Visit CooperVision.com to find a Brilliant Futures certified eye doctor near you.
Your eyes and your vision are under attack. Damaging blue light from the sun, your phone, your computer, your tablet, even light bulbs and car headlights is constantly bombarding you. The good news is our eyes actually already have a line of defense to counter the effects of blue light. This defense is made up of 3 pigments called carotenoids. MacuHealth with MicroMicelle, the only supplement with the exclusive patent on all 3 macular carotenoids and MicroMicelle technology.
OIE Broadcasting is the emerging leader in social media. We use scientific entertainment to drive more patients into your office. Visit oiebroadcasting.com and sign up today.
Welcome back to part 2 of my interview with Dr. Jeff Augustine. In this episode, Dr. Augustine discusses refractive surgery, including SMILE, LASIK, and PRK. If you're new here and you like our interviews, press like, subscribe, share, and hit the bell. Also, please leave comments. Be sure to watch our full-length documentary, Open Your Eyes, on Amazon Prime, Apple TV, iTunes, Google Play, and YouTube Movies and Shows. Let's talk about SMILE, something that I'm very interested in and something very exciting. SMILE stands for small incision lenticular extraction. It's kind of the, even though they've been doing it in Europe, I guess for over 10 years, it's kind of the new kid in the block as far as the US, even though I guess it was approved in 2016, 2017, and then 2018 for astigmatism. Tell us what SMILE is. Walk us through it.
Okay, I started working with SMILE about 6 years ago. We were one of the first centers in the United States to start working with SMILE. And we had 2 lasers. We had one in Cleveland and one in Toledo. And so initially when we started working with it, the energy levels and the surgical skill set associated with doing the procedure was rather difficult for our surgeons. The energy levels had to be adjusted properly. Each of the particular lasers worked differently. We had one surgeon go to Toledo and said that laser was great and dandy. We had the same surgeon come to Cleveland, and we played with different energy levels to remove the lenticle. So as far as the procedure itself, the laser docks to the eye, and it's a femtosecond laser, and it creates different planes in the interstructure of the corneal wall. The cap is created at about 120 microns. Then the assessment is made for the refractive error, and it goes down deeper and creates a refractive plane. And then a small port is created where that corneal lenticle is actually removed, sort of like playing the game Jenga, where you pull a piece out. The same physical principles behind that. So the surgeon has to go in, dock the laser, have the laser do its different types of planes in the cornea, and then he goes in with a spatula and slowly dissects out that corneal lenticle.
And you mentioned energy before. If there's too much energy, what's the downside?
Well, it can be difficult to remove that lenticle depending on energy levels. And also the post-op day 1 outcome may be affiliated with more severe edema and may not have the wow factor that the LASIK patient had. So we started out, and I didn't really embrace SMILE when I first started out 6 years ago. The patients weren't coming in with the wow factor at that day 1 like the LASIK patients were, and so I wasn't embracing it as much as I thought I would. And it was also limited to sphere back in that time period where we weren't able to do the astigmatism patients with the myopia. So that was a limited patient population that I worked with. I think the first year I worked with maybe a couple hundred patients. Then the next year I wasn't really happy with it. It dropped down. And then with the revisions that we had with the energy levels and the expansion of the parameters, then it went up. This past year I've worked with over, in 2021, I've worked with almost 2,000 to 3,000 eyes, and this year we'll probably supersede it at about 5,000 eyes in regards to smile.
How did,
If the patient's parameters fit the smile, then I have the patients have the smile procedure versus the LASIK procedure at this point.
how is the prescription or the amount of lenticle that's removed determined?
It's the basic thing that I talked about a little bit earlier today in regards to the size of the optical zone, the amount of myopia the patient has, and it's calculated that way. There's a nomogram for it. So I have a sheet that I go to, and it'll say this patient's a -5 with 1 diopter of astigmatism. Then it goes over and tells me the size of the lenticle that'll be removed.
Wow, it's fascinating. And how accurate is it?
Right now, the enhancement rate on the enhancement rate with smile in our practice is 1%. That's a secondary procedure rate, and I believe we're at about 98% 20/20 or better.
And compared to LASIK versus smile for needing enhancement or a touch-up, so to speak, as the patients like to talk about.
The enhancement rate for for LASIK patients in our practice is about 4%. But you also have to keep in mind that it's not apples to apples. When we're working with some of our LASIK patients, they may be mixed astigmatism with hyperopia, so the enhancement rate may be not comparable. When I'm dealing with the smile patients, it's all myopia with astigmatism, so it's hard to compare, LASIK and smile on secondary procedural rates. I'm sure if we were just working with LASIK patients with just myopia and astigmatism, both smile and LASIK would be comparable.
And why would somebody have LASIK now over smile, which is an easier procedure to do for the surgeon?
I guess that depends on the surgeon. See, some of our surgeons in our practice prefer smile over LASIK at this juncture. Now, you may have other practices that don't have quite the experience that we have with smile, and they would preference the LASIK procedure. Maybe they don't even have access to a VisuMax laser.
The ones that prefer smile over LASIK that have done both, why do they prefer smile?
I think the reason is that it's one laser, one step,
Interesting.
rather
Now,
than two lasers, two steps.
and what happens if a patient has a corneal scar or has pannus, which are these abnormal blood vessels that have been in the cornea for usually from overwearing your contact lenses?
Yeah, you have to be really careful with patients with corneal scars because using the VisuMax laser, the femtose spots may be blocked. If that's blocked, then it'll create adherences in the interface, so the lenticle will be difficult to remove. When it comes to pannus, I have to be careful with those particular patients because I don't want to get an interface bleed, especially if it's superiorly, and it could go into that 4mm incision site. If you do get a bleed, it can be controlled with neosynephrine and compression on that particular area. But I don't get too worried about pannus unless it's severe. I'm more concerned about the scar and also making sure that there's not a lot of oils that are extruded from around the eye when the procedure is being done.
So if there is oil, what's the negative of the patient of meibomian gland dysfunction and it's producing oil?
Well, what that can do is it can block the laser. So it'll block the process and it creates a problem with creating that lenticle. So you want to have a pristine tear layer as well as cleanliness around the lids and lashes.
And the recovery time for each one, LASIK versus smile, can you compare that?
Recovery times are, well, for instance, I saw about 10 patients this morning. 5 had LASIK, 5 had smile. The recovery is pretty comparable. They're all functional at day 1, but just a little bit different approaches in regards to, that first week and how to take care of the eye. But functionality, they were all fine. I think 90% of my patients this morning were 20/20 and both LASIK and smile.
And if there is a scar, is there a degree of how bad the scar is? And what procedure would you do if the patient does have a scar?
I would lean towards the patient undergoing surface ablation or PRK, depending on the severity of the scar.
And how about for contact sports? Is there an issue with SMILE?
No, the patients that are involved with the contact sports, I tend to lean towards, with this point in time, undergoing a SMILE procedure if they fit the parameters of it. In years past, when I didn't have access to SMILE, I worked with a fair amount of patients that had, had LASIK without any problems with that, as far as flap goes. But I was conscious of it.
And how long does the SMILE procedure take?
About 7 to 8 minutes, depending on the surgeon. I work with 4 different SMILE surgeons. They're all a little bit different.
And but how long is the laser actually on the eye for?
No, the laser's on the eye for about 20 seconds at this point in time. We're gonna see some, as technology gets better, the lasering time will decrease. I believe over in Europe it's about 8 seconds now.
And both eyes are done the same day.
That's correct.
And does the patient feel like they're wearing? I've heard they feel like they're wearing swimming goggles for maybe 24 hours.
No, the patients, I'd let them know that, immediately after the procedure, we'd expect them to notice an improvement. It's not Disney World right away, but they tend to do fairly well immediately post-op. We have them go home and we give them Valium and some Benadryl. They go and sleep for a couple hours.
Now, do you use Valium for LASIK and SMILE before the surgery, or only if somebody's very nervous?
Yeah, we use it before the surgery for all patients, whether it be PRK, SMILE, or cross-linking or anything with that.
And what are some of the surgeon pearls that the surgeon is thinking about?
Some surgical pearls may be, to verbally coach the patient through it. So they able to talk them through. It makes some sort of verbal anesthesia. Our surgeons use. Also, whenever I do a workup on a patient, I have the technicians kind of take them on a field trip into the laser areas, so they become comfortable with that environment. It takes kind of a fear out of the unknown, so it helps reduce anxiety there. Also, being meticulous around and how to surgical pearls to remove the lenticle and make sure that there's no residual cornea left. So the surgeons look at that carefully. Maintaining the integrity of the incision site so there's no corneal abrasions near that site. That can help prevent any ingrowth. Another surgical pearl is washing the interface out. Some of our surgeons wash the interface, some don't. So there's been a mild debate on whether to wash inside that pocket.
And what are some of the side effects that we have to look out for?
Some of the side effects may be regression that may lead towards having a secondary procedure. Also, I'm trying to think.
Any bad infections or visual fluctuations or anything?
I personally have not seen any infections with SMILE in our practice, and but there's always a risk for that. I think I emphasize compliancy with lid hygiene as well as compliancy with utilizing the antibiotics properly. So I have not seen any infections associated with the SMILE procedure in my experience.
And the post-op care, is it antibiotic steroids? Is it anything different?
Yes, it's exactly the same thing as LASIK.
And for about a week?
Yeah, it depends on the severity of the refractive area. May extend the corticosteroid additional week.
My understanding is a lot of combat military personnel and police are choosing SMILE over LASIK.
I have to agree with you.
So again, also a professional, someone who's a high level athlete and maybe a Division I athlete or professional athlete, this is obviously preferred over LASIK. And how about compared to PRK?
I think, if I have the choice, PRK is certainly an elegant, fantastic procedure. In my experience, I have the patients, with PRK do one eye at a time, because the functionality can be very difficult for that first couple weeks. So I generally space the PRK patients out about a month apart on their eyes so that they can get back to work. They can do one eye at a time. I do like PRK. We also do PRK over top of previous LASIK patients for secondary procedures. We don't lift flaps after 2 or 3 years out. We do PRK on top. So that prevents the issue regarding epithelial ingrowth.
So PRK stands for photorefractive keratectomy. So walk us through now. So we talked about LASIK, we talked about SMILE, and now let's talk about the third corneal refractive procedure, PRK, which is photorefractive keratectomy, which you just started talking about. Walk us through that procedure. First thing is, how often is PRK being used compared to LASIK and SMILE? And is it falling out of favor, other than like special cases like you were just speaking about a couple of minutes ago?
Yeah, I think if you look at our particular practice, certainly LASIK and SMILE are practice builders. Generally PRK patients can be a little bit uncomfortable. They have to have more visits to the practice, and their functionality initially isn't that, doesn't have quite the wow factor of LASIK and SMILE. So with PRK, the epithelium was removed, which is about 50 microns. Then the ablation takes place on the anterior stroma based on the refractive error of the patient. Epithelium's removed in our practice with alcohol. And then a bandaged contact lens will be put on the eye. The bandaged lens has no prescription in it, but prevents the eyelid from squeegeeing across the epithelium and also helps with pain management. I have the patient utilize four different types of drops in PRK patients, and we also give them some pain meds because it can be fairly uncomfortable initially when having it. I have the patients utilizing an antibiotic, utilizing corticosteroid, as well as a non-steroidal anti-inflammatory such as ketorolac. I have the patients utilize the ketorolac for the first 3 days, 4 times a day. I see the patient at day 1. I see the patient at day 3. I do a bandage contact lens exchange at day 3. And I see the patient at day 6 and 7 for the bandage contact lens removal. At that point in time, I start tapering the patient on the corticosteroid at 3 times a day for a week, twice a day for a week, 1 time a day for a week, over a month's period of time. During that first 3 days, I have the patient chill the artificial tears in the refrigerator and have them utilize them every 2 hours while awake. So that seems to help with the discomfort. And I've managed those patients quite well in regards to their uncomfortability. It just doesn't have the years ago. PRK was the first procedure in the United States that was utilized, and at that point in time, the patients were pressure patched. That we didn't have good pain management strategies. PRK was not being overwhelmingly embraced back in the early 90s, how it is today. And today it's a very safe procedure that works very, very well for those certain patients that demand that type of procedure.
And what are you using to remove the epithelium? Are you using a laser or are you using something else?
We use alcohol to remove the epithelium.
And how difficult is it to get the epithelium off and to get it nice and clean?
It's not difficult at all. It's put in a little chamber and it's wiped with a Weck cell.
And then after you remove the epithelium, then that's when you bring in the eczema.
Yeah, they do the patient's under the excimer the whole time.
And what is the average time you think that a patient needs to be in the contact lens? The average patient, is it 4 days? Is it a week? What do you think it
No,
is usually?
I'm very conservative when it comes to keeping the bandage contact lens in on the PRK patient. Um, I in the past I may have taken it out too prematurely and the epithelium sloughed. So I keep the patients in that contact for 6 to 7 days with one exchange in the middle.
And do we ever have to worry about recurrent corneal erosions after PRK?
No, actually, when it comes to uh, when it comes to those patients that have recurrent corneal erosion, PRK or PTK is the laser procedure of choice. It creates a new basement membrane, so it cuts down on recurrent erosions. I have seen patients, though, that have had recurrent erosions with PRK. It's very rare, very rare.
MacuHealth, your science-born and tested solutions for visual performance, macular degeneration, and dry eye syndrome. New products coming soon. Embrace the science.
And as far as thinner corneas, is PRK better for a thinner cornea and a higher prescription?
Certainly, PRK can be a great procedure for thin corneas, but I don't go very on the level of myopia with PRK. I tend to not go with high myopia with PRK due to healing responses.
And higher myopia, which procedure would you use with higher myopia before we get to ICLs?
I would lean towards doing a patient with either a thin flap LASIK or would be a smile procedure if they can fit the parameters of it.
And how high can smile go
It
usually?
can go up to it could go up to -10.
And what kind of thickness of a cornea do you need for that?
Well, in order for that lenticle to be removed at a -10, it's probably going to be close to 180 microns. So that's a significant lenticular thickness. So in that case, you have to do the math. The cap would be 120 micron cap. You then have to remove 180 microns out of the center of the cornea and still maintain 275 microns at the base. So you'd have to kind of figure out, well, 275, 180, plus 120. So you're talking probably about a 600 micron cornea. 120, 180. You're catching me up. You're catching me up on my numbers here. 300, 270. Yeah, I'd have to at least 600 microns. But then I also have to look at the curvature of the cornea too, because I don't want to flatten out that cornea too much when it comes to the K values. -10 would significantly change the corneal curvature, and the more the curvatures change, the more susceptibility to aberrations. I would prefer a patient that's a -10 to do an ICL.
And how about LASIK? How high would you go with LASIK? Do you feel comfortable?
With LASIK, when you start to get to those double digits, that's when and 9 and above, I tend to lean towards having those patients do a lens-based procedure such as an ICL. I have worked with, I work with patients -9 with SMILE and LASIK, but it depends on the pachymetry of that patient in order to maintain the structure of that cornea and the strength.
With PRK, patients ask, when can they start watching television? What do you typically tell the patient for something like that?
The next day.
And how about driving?
They're able to, what I do with a PRK patient, I'll have them undergo the procedure on the one eye, and in the meantime, they could wear their normal contact in the opposite eye to correct their vision that way. So that's how they maintain their getting back to work and that type of thing. They can work, they could watch TV, they go on a computer. PRK doesn't slow them down.
How about for driving? Any restriction?
No. If it's a bilateral PRK, then certainly it is.
And what are the side effects that we have to worry about for PRK?
Well, you're going to have to be more cautious of infections associated with that. Also, you're going to have to be very, meticulous on epithelial assessment and understanding how the epithelium heals, and maintaining compliancy with drop regimens as well as pain management.
So let's move over to phakic IOLs, or the ICL, the implantable lenses for the high prescriptions. You know, patients come in, they have a high prescription, a -10, a -12, and they want something done, a procedure. How good are these phakic IOLs, and is it something that it is a reasonable procedure for a patient?
Yeah, I'm a big advocate of the ICLs, especially with the new advent of the EVO lens that has the port in the center. So we no longer have to do the peripheral iridotomy. Also, astigmatism can be addressed now with the toric ICLs. So I'm a very strong component to patients undergoing the ICL. The nice thing about an ICL is that if there was an issue with it, it can be removed. It is a material, so it's very predictable as far as outcomes go. And the patients generally are functional and celebrate vision at that day one post-op because of the dramatic prescription that the patients have. It's a real life changer.
I just want to make sure that the audience understand when I say phakic IOL, it's phakic intraocular lens, and ICL is an implantable Collamer lens.
Correct. Now, an ICL goes behind the iris in front of the natural lens. Let's say a lens-based procedure, we would remove the lens and replace it that way. So two different interocular procedures.
So the next question, of course, is how often do we have to worry about it causing a cataract, and touching the lens when the surgeon is doing the procedure?
The nice thing about the new EVO lens is no peripheral iridotomy is needed. Sometimes if you have an aggressive peripheral iridotomy, that can spark a cataract. So that's been eliminated. The sizing is critically important for the ICL so that it sits in that sulcus properly. So ultrasounds are going to be very, very important, and getting an idea the size of the eye, the anterior chamber depth, so that you can better fit an ICL so it doesn't touch or induce a cataract. If a cataract was to occur with an ICL, the ICL would be removed, the cataract would be removed, and a new lens would be put in its place.
And is that something you've seen quite a bit of, or not really?
Very rare. Very rare. Another issue is the rotation of the ICL in patients that have high amounts of astigmatism. That sizing has to be critically important, because if it rotates out of position, then certainly that can complicate the refractive error of the patient.
And how about a multifocal ICL in people over the age of, I guess, 40?
Yeah, there's not a multifocal ICL. I have worked with patients and done monovision ICL, but they don't have a multifocal. The only multifocal would be an interocular lens, not an ICL.
And I understand that STAR goes from -3 to -15. Is there anything above -15 for those patients that are even -18, -20?
I have worked with patients that are outside those parameters. I think it goes up to actually -16, I believe. Okay. Maybe you're right, maybe I'm wrong. But I worked with a patient, she was a -23, and we put the ICL in a -16, and then a month later we did LASIK on top.
And how did she do?
She came in, it's pretty funny, because her best corrected visual acuity on a -23 was about 20/30, 20/40 with those optics. She was a Syrian refugee, and she came in very introverted and hardly made any eye contact with me. Within 6 months of having that procedure, she blossomed into a new person.
Really?
Yeah, it was fantastic.
So that's a tremendous story. Are there any other ICLs that are approved that don't need that you don't have to worry about doing a peripheral iridotomy besides EVO?
No, that's the only one that I'm aware of. And here in the United States, we only have ICLs for myopia and astigmatism. in different countries, they have ICLs for hyperopia and astigmatism.
So what besides worrying about a cataract, what are the side effects that we have to worry about ICLs?
Well, we talked about rotation, right?
Yes.
And we also, the other thing that we have to be cautious of is interocular pressure during that initial postoperative period. Because if any of the, let's say the lens moves forward, the EVO may be blocked by a viscoelastic agent, then the pressure can elevate quickly.
And what's the post-operative period like, and what kind of medication drops do they need?
It's very, very similar to a cataract surgery. We have a combination drop that has ketorolac in it, prednisone in it, and antibiotic in it. And it's generally 3 times a day for the first week, 1 time a day for the next 2 weeks. You have to be these patients have to be a little bit cautious, like cataract patients with bending over and lifting, that type of thing for the initial post-operative period.
Is that drop compounded?
Yes.
And what do you happen to know where you guys get that from? Offhand?
No, I forget the name of the company that does that. I'm sorry.
No, I mean, that's pretty cool though, that you put all 3 drops in one bottle and make it easy for the patient.
Yeah, it's great. We dispense it to them as well. You know, we have an ambulatory surgery center that's connected to the LASIK center. So, you know, they're right next door to us, and that's where they're given the drop.
Now let's talk about someone who had cataract surgery. So we were talking about before non-cataract surgery, younger people,
Right.
And now people get older, they need cataract surgery, and there's great options for them as far as implants, as far as multifocal and premium IOLs. Can you talk about those and your experience?
Yeah, the lens that I've been leaning towards lately is called the PanOptix lens. It's a multifocal interocular lens, and it's been our go-to lens because it has given us the most functional vision, both distance and near, without significant aberrations. So that's our go-to. Might be Bausch and Lomb. I'm not sure who makes it off the top of my head.
Okay, so
It could be
what's the
it could be an
advantage of it?
Alpine-based one. I'm not sure.
What's the advantages of it? I interrupted you.
Because it's giving the most usable vision in this zone here, as well as good distance vision and having less aberrations at night.
So let's talk about laser assisted cataract surgery using the femto in cataract surgery. Talk about the pros and cons of that.
I don't work a lot on that cataract side, and we no longer use that particular laser based. We no longer use that. Wiley tends to use just phaco only.
And what do you think the future is? You think we're going to see bilateral cataract surgery?
Yeah, I think that's being done already around the United States. Also, you're seeing having instead of having a formal ambulatory surgery center, a lot of these cataracts are being office-based done now.
And the advantage and disadvantage of it doing office-based versus ambulatory?
I think the office-based may be a little bit more, maybe more convenient, maybe more economical to the practice. We've thought about that idea, but we're still leaning towards. Wiley tends to in our surgeries are in ambulatory surgery center, and he's staying with that.
And have you?
I think those questions. I think that'd be better addressed by the cataract surgeon than me.
And you think, how long into have you guys started doing bilateral cataract surgery where you are yet? And how long into you think that may be something that we'll see universally throughout the U.S.?
We have not done bilateral cataract surgery, but we do bilateral lens replacement surgery because it's a different because of insurance based, and so we have to do it.
for bilateral cataract surgery, I guess we have to really worry about endophthalmitis.
Yes, I would think that would be something.
That would be something I guess we would worry about. Well, this has been very comprehensive, Jeff. You've been very generous with your time, and you have tremendous knowledge in this area of surgical procedures. Is there anything that I left out that you'd like to that we should talk about?
I just we talked highly about Smile, but I LASIK and PRK are certainly fantastic. They're all fantastic. They're all fantastic. The technology in PRK, LASIK, and Smile is awesome. There's some distinct advantages to each of those types of procedures. I celebrate all three of those procedures, and I'm looking forward to embracing the new technologies that continue to evolve in the laser vision world. From when I started to where I am today, it's been an evolution like monkey to man, and it's just been a fantastic ride.
It must be wonderful to have such happy patients.
Yeah, I have a great job. I have a great job. Considering you're able to remove a visual handicap, change a patient's life for the better. That's a great career.
I mean, you talked about.
I love the celebration of vision. I love the celebration of vision. Day one post-op is it.
I mean, you talked about that one patient who was over -20 and her whole personality changed. Is there any other patient that you could tell us about that may stand out in your mind that the procedure just changed their life?
Well, for instance, I did a workup on a patient. He came in, he's a football coach, high school football coach, and his refractive error was -50.
-50?
-0.50.
Oh,
half. Half diopter, not 50, but half diopter.
Okay.
So I go, are you really, is this really going to be significant for you? We have to look at the risk benefit ratio. Do you wear your glasses all the time? He's like, yeah, I want to see my players, and it's night and I can't see good. And I said, do you wear contacts? He's like, nope, just glasses only for nighttime driving. I said, other than that, you don't wear them. He goes, no. He goes, but I want the procedure. I saw him and he was about 20-30 uncorrected, maybe 20-25 uncorrected. And I saw him this morning. He had his procedure done yesterday, and he's 20-15 this morning. And I go, was this worth it? Is this better for you? And he goes, I love it. It's fantastic. So you go from that extreme to this extreme.
That's wonderful. And that's a real type A personality, a football coach with a -0.5, and he wants a procedure.
Yeah.
And which procedure was done on him? You might have said it, but I missed it.
He had a LASIK procedure done.
Wow.
If the lenticle size on a half diopter would be I don't think Smile even does a -0.5. It would be too thin.
So interesting. Such a great story. Well, Dr. Augustine, if people want to find out more about you, or they want to get in contact with you and your clinic,
Yes.
How can they do that?
So you could go to clearchoicelasiccenter.com, or you can reach us at 440-740-0400. That's the easiest way to get. Just Google us or just easily Google us. We have 2 locations. One's in Brecksville, Ohio, and the other one's in Toledo. It's called the Toledo LASIK Center, and our surgeons go to and from. The surgeons I work with are top notch. I work with Shamik Bafna, William Wiley, and Kathy G. And then we also work with another ophthalmologist by name of Arjan Hura. They're all fantastic surgeons. I've been working with those guys for decades. So yeah, you're in a good place when you come see us.
Well, thank you, Dr. Augustine. Thank you for sharing your knowledge and this great information that the public really wants to know about, and a lot of optometrists need to know about it. This is Dr. Kerry Gelb for Open Your Eyes. Thank you for watching.
OIE Broadcasting is the emerging leader in social media. We use scientific entertainment to drive more patients into your office. Visit oiebroadcasting.com and sign up today.
Your eyes and your vision are under attack. Damaging blue light from the sun, your phone, your computer, your tablet, even light bulbs and car headlights is constantly bombarding you. The good news is our eyes actually already have a line of defense to counter the effects of blue light. This defense is made up of 3 pigments called carotenoids. MacuHealth with Micromicelle, the only supplement with the exclusive patent on all 3 macular carotenoids and Micromicelle technology.
Fitting multifocal contact lenses presents a big opportunity to meet patient needs while growing your practice. Alcon is your partner not only with our innovative portfolio, but through e-learning. Learn to enhance your multifocal strategy today with the Alcon Experience Academy.
Each generation was supposed to be healthier than the last one. Lifespan was supposed to be increasing. We were supposed to be in this paradise by now. Instead of getting healthier and healthier, it seems to have gone the opposite way.
Millennials were projected to be the first generation in history to not outlive the generation before them.
We are certainly headed for disaster.
I think a lot of people are beginning to question the whole story.
We live in a time where the paradigms are shifting.
And the optometrist, in my opinion, is one of the best kept secrets.
The public doesn't realize about going to the eye doctor. So many different diseases actually manifest in the eye. The back of the eye is the only place in the body that you could actually see the blood vessels.
Completely non-invasively, you could screen thousands of people, not just for their eye health, but for their whole body health.
Because this disease is here, it's also going to be here.
And I can look into the back of my eyeball, and there are expert doctors on the ground who are looking at my eyeball while I'm doing it.
The eye is the canary of the mind.
The eye is the kingdom.
Will everyone please open their eyes?
Since I bought Safe For You, my dad makes me clean his boat.
Es natural y es un buen producto.
Every time I go back to school, my mom always makes sure that I have my Safe For You products. I bring extra, and my roommates certainly don't mind.
It's a good thing I had Safe For You to clean up after this little guy.
When my hands get dry, I like to wash them with Safe For You.
And most importantly, the reason why I buy Safe For You is because it's safe for me and you.